So we have now reached the top of the hour, and it's time for me to welcome you everyone to the SNOMED CT web series. I'm Anne Høyen, and I'm an education and product support specialist with SNOMED International, and I also have the pleasure of being your host today. And I'm pleased to welcome you to this SNOMED CT implementation webinar, which is part of our web series program. SNOMED International hosts three kinds of webinars. We have the clinical webinars, where clinicians working with SNOMED CT share their real-world experiences with using SNOMED CT in their practice. And we also have the research webinars, and they involve presentations from distinguished researchers from the SNOMED CT community, showcasing current research involving SNOMED CT. And then we have the implementation webinars, where we either address specific topics relevant to SNOMED CT implementations, or we have presentations from the community of practice sharing their implementation experiences. And I encourage you all to visit the web series website, where you can get an overview of upcoming webinars, and you can listen to the recordings of previous webinars, and you see the URL for the web series site here. If you wish to sign up for the user support reference group, which will give you an opportunity to connect with fellow SNOMED CT implementers, or you just want to observe or engage in the discussions in the group, then please send me an email using this email address, and I will forward you the registration form. But you can also sign up via the Confluence site where there is a link to the registration form. So before we start, I just have a couple of housekeeping items. You'll notice that your microphone is disabled, but if you have any questions as we go along, then please don't hesitate to enter your questions into the Q&A box, and our presenter will try to answer as many questions as possible, either during the presentation or afterwards. And finally, our webinars are recorded and published on the site to give people in other time zones a possibility to listen and also see the presentations afterwards. It's also an opportunity for you to share them with your network. But now it's a pleasure for me to welcome today's presentation. The presentation today is entitled Implementation Adventures in SNOMEDLand. Lessons learned from 6 years of supporting SNOMED CT adoption in the NHS. And the presentation will be given by Mr. Pete Turnbull. Pete Turnbull has worked in clinical informatics at the NHS for 13 years, specializing in electronic patient record interoperability standards and implementations. Pete is currently NHS Digital's Principal Terminology Implementation Specialist, leading the team that supports care organizations, standards organizations, and IT system vendors in implementing SNOMED CT and other standards needed by the NHS. He's also the chair of the UK SNOMED CT Implementation Forum. So as you can hear, we here have a person with a great deal of experience with real-world SNOMED CT implementation, and I hope that you will all enjoy hearing about the UK SNOMED CT adventure. So welcome, Pete, and thank you for being here today. The floor or the screen is now yours.
Thank you very much. Let me just switch over. Which I hope you can all now see. Yes, good morning. Thank you for having me today. Yeah, so my name is Pete Turnbull. I will skip over a little bit about me because Anne summed it up better than I could. But before I go on, I better explain really who NHS Digital are. We are the part of the NHS that designs information standards, messaging architectures, networking, that sort of thing. We're the NHS's digital partner, and national services like demographic lookups, electronic referrals, electronic prescribing, all those things are things that we provide, and we either define them or we define and deliver them ourselves. From a SNOMED perspective, we are the National Release Centre for UK SNOMED CT. We have 4 UK extensions that sit on top of the international core for SNOMED, and we hold the license for SNOMED CT on behalf of the nation. And the reason this is Adventures in SNOMEDLand rather than just in the NHS is we very much declared SNOMED CT as the terminology of the NHS and of the UK. We did that in 2015 via something called an Information Standards Notice. If you want to look at it, you should Google SCCI 0034, which is its rather catchy title. And it's actually enshrined in law that ISNs must be adhered to. So all system providers who use a terminology in their system or communicate using a terminology now need to start moving to SNOMED because that is the terminology of the NHS. Today, a talk in 2 and a bit parts. Part 1 is really focusing on primary care. I moved over from working in primary care interoperability and messaging to work on a SNOMED CT implementation project in 2014. I wasn't previously the only principal implementation specialist. There were 2 of us. I had my colleague Denise Downs, who retired this year. So I'm currently the only one left, but I do have an amazing team that support the work of the NHS. And the NHS in the UK is very much divided in its maturity. Primary care systems, extremely mature, extremely informatically complex. Secondary care systems, sometimes less so. And so the second part of this is going to be about mental health systems, which rather than primary care being very technical solutions and problems, mental health, much more holistic problems, much more about the very first principles of implementing SNOMED CT into environments that don't really have terminologies. And then lastly, very briefly, just some news on our plans for the future and wondering what we'll find out next in other care settings. So without further ado, the possibly slightly unrepresentative world of UK primary care. Implementation planning is always really effective when you have a very, very clear idea of where you're starting from, not just where you're trying to get to. And to understand where primary care was, you need to know a little tiny bit of history, because primary care has a really long history of computerization. The first date on this slide is a bit contentious. I've read it being 1967 through to about 1971, but certainly around 1970, Dr. John Priest, just outside Exeter, became the first UK GP to use a computer in his consulting room. And more amazingly, in the village of Ottery St. Mary, which sounds like something from an Agatha Christie show, but is in fact a real place, in 1975, their health centre became the world's first paperless GP practice. That's a picture of Dr. Bradshaw at Ottery St. Mary, and you will notice paperless practice. The more observant of you will spot a small roll-top desk full of paper. What we're saying there is that the electronic patient record was the definitive patient record, and their patient record recording was paperless. So GPs all the way through the late 60s through the 70s were really excited about computerization. And in a weirdly lucid moment, the government of the 1980s declared that the nation was to be computer literate. And they started subsidizing hardware and putting computers into every school. And they gave away 150 computers to GP systems, to GP practices rather, for GPs to use. They didn't come with any specific software. But this started a real revolution of GPs driving informatics. So in the mid-80s, using the AB system, we've got James Reed, David Markwell, and Tim Benson, who bring us Read codes in 1986. And around about the same time, about 20 miles from where I'm talking to you from today in rural North Yorkshire, Peter Sowerby, David Stables, and Tony Jones are creating the Egton Medical Information System in the small village of Egton. And that would later be shortened to become EMIS, and EMIS are now the largest supplier of primary care IT systems in the UK. By the 1990s, by 1990, in fact, the Department of Health has bought Read codes and set up a terminology service. And by 1996, 96% of GP practices are computerized, and between 15 and 20% of them, the numbers are unclear, are fully electronic in their patient records. So what does this history lesson mean for how we started the primary care transition? Well, we've got some fairly big advantages in primary care. GPs and practice staff have been using terminologies to put coded information into their EPRs for over 30 years. It's just the de facto way of recording clinical information in primary care. Also, system suppliers were really adept at manipulating terminologies. They weren't using SNOMED for clinical data, they were using Readv2 and CTv3, but they knew about SNOMED. We did use SNOMED, just not for the clinical payload. So in a system called GP to GP, which is how we move medical records around primary care systems, the SNOMED CT record artifact hierarchy was being used to help structure the EPR payload and make the payload more computable and more easy to understand. A really key thing and we'll come back to this idea a few times in this talk, is that the terminology interfaces that they used to put data into systems were amazingly well developed. And there were even situations where GPs didn't even realize they were putting coded information into systems. The interfaces were that slick. So you could be recording narrative information, and in the background, GPIT systems were putting read codes at the time and CTv3 codes behind those words to populate the data. There was one other big advantage, of course, in that Readv2 and CTv3 are precursor terminologies for SNOMED. If you know your SNOMED history, SNOMED CT is made by taking CTv3 and SNOMED RT and smashing them together. And that's why you end up with SNOMED CT. Well, actually, you end up with a bit of a mess, but about 3 years later, you end up with SNOMED CT. So an admission of guilt at this point. When I was writing this presentation, I did get a little bit carried away. And the first time I ran through it, it was 3 hours and 26 minutes long. So instead of going through every single complication that we found in primary care and how we solved it, I want to focus in on just 3 major ones at the moment. And the first one of those is that mapping historical data safely and accurately has some challenges, and we've got a tremendous amount of historical data that we need to take from older terminologies to SNOMED. In fact, some of these terminologies have already gone through, these data items rather, have already gone through a number of terminological changes. So we started off in the early 80s and in 70s with Oxmis codes. They became 4-byte read codes, which became 5-byte read codes, which in some cases then went on to become CTv3 codes. And now that same information is becoming SNOMED CT. And mapping from Readv2 and CTv3 to SNOMED is not as easy as you might think. For instance, read synonyms are often not true synonyms. There's a few problems with read, and this isn't bashing read codes. Read codes were amazing, but read codes were also made in 1986. You know, it's 13 years before Jim Semino would write his Desiderata. We were still feeling around the edges of informatics at this point, and read codes were revolutionary, but they do have some problems when you look at them through a modern informatics lens. For instance, if we look at this code here, if you don't know much about read codes, don't worry about that, because you can consider this bit, the actual read code itself, basically equivalent to a SNOMED CT concept ID, or that'll do for today at least. And the term code here, if you add that to the read code, you get something roughly equivalent to a SNOMED CT description ID. So from a concept perspective, M080 dot should all be the same thing, but in read it is not. It is cellulitis of finger with one synonym, nail bed infection with another, septic thumb with another, cellulitis of thumb with another synonym. So these aren't true synonyms. We also had the issue that generating mapping tables algorithmically is not sufficient on its own. We needed to human review and assure the mapping tables because they needed to be clinically safe because of the volumes of data we're looking at. There are tens of billions of historical EPR data items sitting in UK primary care systems. And in fact, we know, because we get the information from GP suppliers, that over 2 billion new coded clinical data items go into primary care EPRs every single year. As far as the number of codes available goes, for read, we couldn't consider just the read code. We had to consider it at the term level, and there were 102,057 terms in read, and we've also got 350,000 CTv3 concepts. So there's plenty of stuff going on there. So how do we solve these problems? Well, as with so many things, you assemble a team, and our team of informatic Avengers, who refused to wear capes, even though I asked them to, were 6 GPs with informatic and clinical safety training, not just NHS Digital clinical leads. We had people from Primus, which is part of Nottingham University, and we had representatives of an organisation called the Joint GPIT Committee, which is a sort of special interest group that represents the needs of GPs from the profession, from the British Medical Association and the Royal College of GPs. Leading them was Dr. Jeremy Rogers, our chief terminologist at NHS Digital, the man with ultimate responsibility for publishing SNOMED CT, or the UK part of it, and previously Read and CTv3, and by happenstance, my boss, and also a chap called Andrew Frangleton from an organisation called Clinical Architecture. Jeremy had loads and loads of tools for mapping Read to CTv3 to SNOMED that he's built over the years. Andrew had a completely independent set of tools, nothing to do with Jeremy's, not based on the same technology, that we could use to compare them. So we started looking at the mapping tables and started to review them. And the methodology we used went a little bit like this. In the most visually unexciting episode of Robot Wars ever, we had Rogers versus Frangleton algorithm battle. That created us a set of mapping tables that were algorithmically assured by a computer system using lots of heuristic rules for the GPs to then look at. The GPs were then given batches. We developed them, we split them into teams. I think we had a red team and a blue team, and they were given batches of codes and told to basically look at the row and see, are you happy with the algorithmic map? And if they were both happy, because they were split into teams of 2, that was great, tick in the box, that is now an assured map. If they weren't happy, they couldn't just say, I don't like that map. They had to come on with a better map. Where they came up with the same better map individually, that became the new map. And Andrew and Jeremy would assess that map to see if there was a new algorithmic rule they could write based on that decision. Where they disagreed and they came up with a different new map, a third GP was brought in to act as a referee. And often very, very long discussions ensued on why one map was better than another map. Often not just about what the term said or where things were in the hierarchy, but from where we knew how these things got used, because these are GPs who had a huge amount of information on the needs of the profession and how the profession as a whole used some codes, which wasn't necessarily what you would expect them to be used for. So these discussions went along a long time, and we realized we weren't going to have time to assure every single row of the mapping tables. However, it turns out that doesn't actually matter, because the number of codes that exist in a terminology is very, very different from the number of codes that actually get used. So this is a SQL query that brings back some usage data from a single system. I'm not going to say which one, from a single year. And I think the year was 2015, it might be 2016. And what we see here is that this particular system, I think we had 943 million EPR data items put into this particular vendor system that year. 40 million of those pretty much are just blood pressures. Other big hitters were, as you might expect, pathology results. And actually, if we looked at the amount of codes that made up 99.95% of all the data that got used, that was a set of less than 7,000 codes. So first of all, we promoted them in our human review to make sure we did all those. We then started expanding our target, and there's a very, very long tail of code usage. So from our first 7,000 codes, we then assured, human beings assured 20,000 of the top codes. That got us to 99.96%, just 0.1% more. By the time we finished the project, we'd assured the top 60,000 codes, and that got us to 99.97%. So a huge rounding up. There's loads and loads of codes which don't get used very often. They're still important. We still need to look at them, but we could focus our main efforts on generating better and better algorithms from the codes that get used most. And by the end of this, we had really, really strong mapping tables, and they've really stood the test of time. It's very, very rare anyone queries the mapping table, and actually we've stopped updating them now entirely. They're now absolutely static because we've proved they're fit for purpose in real life. And what you end up with is something like this. And there is our old friend cellulitis finger toe. So this M80 dot, this has become a number of different SNOMED CT concepts. Cellulitis of finger of toe is now cellulitis of digit. Nail bed infection is infected nail bed. Septic thumb is infected thumb. And that septic versus infected is something that would go into the term matching algorithms. It might not have started like that, but we might have not got a very good map to septic thumb. But we realized actually in this particular case, if we look at where things are in the hierarchy, septic and infected are basically the same. So we could start mapping septic to infected and see how that affected the mapping tables. So those are the sorts of things that we did to improve the mapping tables and improve the algorithms that created them. But, and this is true whether you're looking at read-coded data or local coded data or some other terminology, you don't have to stop just looking at codes. There's other things you can do to make your maps better. For instance, here we have 38A2 dot Berg balance test. This is a procedure for performing a balance test, so it maps to the Berg balance test procedure. But often what we would find in records was that wasn't sitting there by itself. If we step back a little bit, we see that Berg balance test is often associated with a value, with a score. And we can then create another set of mappings that sit over the top and say where this code is by itself, map it to the procedure for Berg balance test. Where it is with a numerical value, you can map it to Berg balance score, the observable entity. And suddenly, by doing this, you're actually improving your data quality. This wasn't necessarily people getting the code wrong. Often in Read, there wasn't really the differentiation between the procedure and the observable entity. They just had one code for Berg balance test. And so that was used for everything. But in SNOMED, you've got more choice. You've got a properly curated terminology that puts observable entities next to values rather than findings, rather than procedures. So we can make that change in the data migration if we just step back a bit and look not just at the code, but at the data around it. And you can do more than that. We didn't need to, luckily, but you could also, if you were looking at something which wasn't read coded or wasn't in a terminology at all, but you were matching by term, you could look at where that data sits in the record. That can give you huge amounts of information about a more appropriate map. You could look at whether it was associated with other data values. You can look at it as modifiers. Modifiers are a big thing. I've seen family history screens where family history is recorded against family history of, and then lots of codes, and then a yes or no next to them stored as a modifier. It's really important if you've got modifiers in your system to be aware of them when you do the mapping. So a negative family history doesn't become a positive family history. So there's all sorts of extra things you can do. Don't just get looked at, don't just focus in on the codes, you're missing opportunities. So that's how we did things with mapping. The other thing we had to do was look at the mixed terminology estate. We did, and I remember sitting in a conferencing suite in 2014 with the rest of the team and with all the system suppliers. We genuinely did consider, were we going to have National SNOMED Switch On Day, where we all sing Happy SNOMED and eat SNOMED cake, and we'd have some comically big switches made and people would pull them, and then at midnight on that day, everyone would move to SNOMED. In hindsight, that was a really naive thing to even consider, because the realities of software development are that different suppliers need massively different amounts of time to implement. And we wanted to be in a situation where we didn't have to hold back faster implementing suppliers, but we also didn't want to put overdue pressure on slower implementers that would cause potential issues and problems. The reason they all needed different systems, the usual things, to be honest, they all did the same job. They all do the job of primary care computing, but they have different system architectures, and different system architectures have different challenges. For example, some of the challenges are about scaling. People based on Read were used to having to handle 100,000 codes. So a lot of their functions were efficient when applied to 100,000 codes. But compare that to putting them against the 2,800,000 SNOMED CT descriptions, and suddenly those functional areas become struggled. They need to be made more efficient. Architectures might need to change radically. We also had massively different company sizes, and we also had different release architectures. We were in a situation where we have single centrally hosted systems versus multiple cloud hosted systems, and we still had plenty of systems where the EPR was sitting under the reception desk on a server. And we had a difference in release timescales of people who could release across their entire estate pretty much instantly, through to people that would take 6 to 8 weeks to implement across their estate as they rolled out. So why is this a problem? Well, it's a problem because in the UK, entire electronic patient records get transferred between GP systems at very high volumes, tens of thousands of times every week. I suspect a little bit less at the moment because people aren't moving house or moving around much. But in a normal world, if you move house and you get a new GP, your EMIS electronic patient record might get automatically sucked out of an EMIS system and put into a TPP system. And because of that, we were in a situation where if EMIS had moved to SNOMED, but TPP hadn't, EMIS would be sending them SNOMED codes that they couldn't understand. So we needed to maintain interoperability, and we needed a situation where we were controlling the transition while people were developing to make sure that they could all continue to communicate with each other. And the way we did that wasn't really rocket science. The first thing you need to do is make sure that every single individual data item you have can exist in both terminologies at the same time, and then people can consume the thing they want. We've already got our mapping tables, so we use the mapping tables to make all our EPR data, both historical and the new data going in, available both in Read and in SNOMED. And some suppliers decided to actually write the SNOMED to their database and have little paired up clusters of values. Some suppliers decided to map in real time whenever they needed to. But whenever you sent data, whenever you shared data, you provide both codes. And we'd actually been sending SNOMED mappings for a while, but we'd never switched on the use of them. We now switched on the use of them because we had these clinically assured mapping tables. And the maps were at the concept ID level because we wanted to preserve the original term that the GP chose when they put that data into the system. So the read code of PKYZ700, which is Angelman syndrome, became this SNOMED CT concept here, but the original term was the thing that was used to describe the EPR data entry on the screen. So people, though, wanted to move over to SNOMED. They wanted to allow their users to start picking SNOMED terms and writing SNOMED concepts and description IDs. That's fine, but in order to maintain interoperability, we had to tether them to something we call the GP subset. The GP subset is the part of SNOMED which has an equivalent concept in read. And it was identified by looking at the forward mapping tables and creating a set of backwards mapping tables. I'll talk about how we did that in a moment. We needed to do this at the description ID level for reasons I'll also explain. But again, our Angelman syndrome here now as a description ID chosen in SNOMED can flow back to a read system because it has the SNOMED description and the read concept and read term. Why can we not just use the forward mapping tables backwards to create our GP subset? Why do we need a subset at all? Well, if we look at this, this is a little slice of the forward mapping table. And if we look at this, PKYZ500, Happy Puppet Syndrome, has one row. Happy Puppet Syndrome is actually a synonym of Angelman syndrome. And because it's got one row in the forwards map, we can absolutely use that backwards. But for reasons lost in history, and this is another sort of peculiarity of read, Angelman syndrome is actually in read twice under two different concepts. So in the forward mapping table, there are 4 rows for Angelman syndrome. And if someone in a SNOMED system has used the Angelman syndrome synonym with this description ID, there are 3 rows back to read. And a computer system can't handle knowing which one to use. We have to specifically tell it. How do we decide? Well, a number of things. This row here, the term text is identical. It doesn't have Angelman syndrome without its apostrophe. It doesn't have Happy Puppet syndrome. It's definitely Angelman syndrome. So that's a very positive thing for this particular row. The other thing is that this 00 here indicates that this is a SNOMED CT, a read preferred term. And preferred terms are always preferable for various reasons, not least of which we've got one supplier who only uses preferred terms. And lastly, this is a clinically assured row, and backward maps always have to be a clinically assured row. So our backwards mapping table looks like that. And it has 2 rows, and we support 2 description IDs for Angelman syndrome, Happy Puppet synonym, Angelman synonym, and each one of those goes back to one read code. You'll notice they go back to different read concepts, and that's fine for a read system to handle. So that was fine for a little while, but it'd be very pointless to move to SNOMED and then only have the content that was available in read. So whilst suppliers were developing their mapping tables, we asked them to do something else. We already had degrade handling. We were already in a situation where read codes, you've got 102,057 terms. CTv3, you've got over 300,000 terms. And we have one system using CTv3 and 3 systems using Read2. So we already had a way of systems gracefully handling codes they couldn't understand. We also had a few legacy local codes still flying around. So we asked them to expand that and give some extra options for SNOMED CT. So if a read system receives a SNOMED CT concept that it can't understand, it went through a slightly improved degrade handling mechanism, and we suggested 4 possible options. A human being could just select the closest read code they could find. Or we could actually use the mapping tables and the SNOMED hierarchies to work out what the closest parent within the GP subset was for this particular SNOMED code. Suppliers could create a local code that would then be replaced with a SNOMED code when they moved to SNOMED. Or if a clinical care professional, because these were all overseen by clinical care professionals, they might decide that actually I don't even need that thing coded. I'm never going to report on it. It's never going to have to interact with decision support. I'm fine just having that as a piece of text in the EPR. So in something like acute constipation, we could, if we wanted, have a user just say, well, it's a constipation symptom. So I've got a constipation symptom concept in read, I'll put it in there, and the system would automatically write acute constipation as a text note next to it. So that information wasn't lost to a human being reading the record. Or the closest GP subset concept ID in Read or Read code was 19C2 constipated, which again, we would append acute constipation as a text note too, so that little nuance of extra information wasn't completely lost. You could have a local code, or you could just take the whole thing and make it text. The reason this was acceptable, particularly because it was a time-boxed piece of work and people wouldn't always be in this time of still being needing Read, the volumes of codes beyond the subset were going to start out being extremely small. We've already seen that even though GPs had hundreds of thousands of codes to choose from, they fundamentally chose from the same set of around sort of 7,000 to 10,000. So whilst there will be certain instances of people using codes beyond the subset, most people would still be using the same codes. And as long as we don't get something like a global pandemic, we'll be fine. Luckily, we did this in 2018. The last problem we had was converting Read report logic to SNOMED CT. Because we've got these advanced informatics systems, practices absolutely rely on technologies and functions that run on codes. Practices rely on reports and triggers and all sorts of things. All their recalls and reminders are based on looking at read codes in the record and identifying patients in particular cohorts. They've got real-time clinical decision support logic constantly running in the background, not just looking at historical data, but even monitoring data in real time as it's entered into the EPR. And some of our payment systems and our outcome monitoring is based on complex queries about patient lists and the care given to patients. We've got a thing called the Quality and Outcomes Framework in England, QOF, and that runs on a variety of fairly complex business rules that have complex code sets and complex logic functions that are used to run them. For instance, imagine you are looking at your diabetes outcomes. You might write a report that says, give me everyone with diabetes mellitus and all those codes, except people with malnutrition related diabetes. And from those, I want everyone who's a current or recent smoker and who have a BMI over 25 and who don't have a smoking cessation advice code or a weight loss advised code in their record. So it's these sort of nested, multi-layered logical statements that ran practices, and they were completely reliant on them. I have a colleague, Andrew Perry, who did a tremendous amount of work in this area to see if there was some clever algorithmic way that we could turn a Read report into a SNOMED report and keep it clinically safe, accurate and useful. And he concluded that we could not. And I absolutely believe him because he worked extremely hard on finding a solution. For instance, this is the Read code for constipation. And it's at this point, by the way, I realized that I've used constipation as my main Read code example, which anyway, moving on. So we've got constipation here. One of the things you might notice is the very first child of constipation in Read is not constipated. We've then got constipated, and then we've got the classification sounding constipation not otherwise specified, NOS. Compare that, and I'm sorry, this is going to be quite small on the screen, to the children of constipation in SNOMED CT, and indeed constipation itself at the bottom there. A huge number of concepts. However, we can't say algorithmically, does someone want something like perceived constipation? Perceived constipation isn't technically constipation per se. It's someone who's taking a lot of laxative because they think they're constipated all the time, and it's the only way they can keep regular. If you wanted everyone who was constipated in your report, do you want perceived constipation in there? That's something we couldn't decide algorithmically. We also had lots of problems where things had moved hierarchies between Read and SNOMED, where medical knowledge had changed and Read had a concept under one parent, but in fact now it was considered as a concept of another parent. So these are the sorts of things that would stop us algorithmically changing reporting. And since we didn't have a solution for this, why have I left this in a talk about solutions for problems? Because there isn't going to be a computerized or informatic solution for every single problem you face. There just isn't. We had no algorithmic solution, but what we could do is try and reduce the burden on practices. So we knew we were going to have to ask practices to review and rewrite almost all of their reports. So we encourage suppliers to give reporting functions really, really early in their development phase. We encourage them to flag complex reports because these are the ones most likely to cause problems. We had dual coding by this point, which was fantastic because then we had a test environment that was your real data available both in Read and SNOMED at the same time. So you could run your Read report and then run your SNOMED equivalent report and you could see whether they were equivalent or not. So that was an amazingly powerful tool to have. It wasn't just about practice reporting or indeed supplier reporting. Suppliers also use third-party decision support systems, so we encourage them to go to their decision support providers very, very early in their process and talk to them about switching from a Read or CTv3 based decision support mechanism to a SNOMED CT based one. And we were very encouraged. We talked to one of the major suppliers is someone called First Data Bank, and when we talked to them, they were already ready for SNOMED CT, and they were just ready to speak to suppliers about what the change would be. So that was really encouraging. We did expect a bit of a backlash from practices, and it was understandable. GPs were really, really busy. We were putting extra work on them. But the surprising thing we actually found is that many users just acknowledged that, you know what, this is a bit of an opportunity for us. We don't really do the housekeeping we should in our reports. We've got loads of reports in our reporting folders that we don't actually use anymore. We've got loads of reports we haven't reviewed for years, even though there've been new codes, and they did see it as an opportunity. So we did help them as much as we could. We tried to get them really good tooling. We created lots and lots of solid guidance and offered lots of support. My colleague Denise Downs created a huge volume of educational and training material just about writing reports in SNOMED that the GP system suppliers could use and change and republish as their own and that sort of thing. So to sum up part one then, and it sounds obvious when you write it down, but informatically mature and complicated systems have mature and complicated problems. And I've only touched on 3 of them today. In the full list that I came up with last week, I think there were about 14 major issues that we had that we needed to solve, and almost all of them were solved by either Jeremy or Andrew being terribly clever with informatics, but also by GPs and system suppliers all working together. We didn't need to educate suppliers much on SNOMED. We did a little bit of education. We did need to educate users a bit. But underpinning all of this, constantly we solved our problems with mass collaboration. I didn't move primary care to SNOMED. NHS Digital didn't move it either. We all moved, and we moved together, and we talked to each other. And the system suppliers, who are natural competitors, not natural collaborators, collaborated amazingly and shared ideas and shared what they found and shared feedback with us. And we couldn't have done it without them. So when we start looking outside of primary care, we go into a very, very different environment. And a disclaimer, first of all, nothing I am about to say about EPR systems outside of primary care should be seen as me being derogatory of them or being overly critical of them. I was lucky enough to have a really good clinical lead when I started, and we were looking through the primary care systems that existed at the time. And when I started in IT, there were 11 in the UK. And we were going through how they all worked and their informatic architectures and all this other stuff. And I said to him, which are the good systems, which are the bad systems? And he went, no, that's the wrong way to think about this. We don't do good systems and bad systems because it's a stupid moniker and it doesn't help anyone. All we have is different systems that need to communicate with each other. And I genuinely believe that, and I've carried that with me for 14 years, that good systems and bad systems is just not a thing. Secondary care systems do not have decades of computerization. They're also not driven by terminologies like primary care already was. So what are they like? Well, mental health EPR systems vary massively in complexity, but are fundamentally not underpinned by terminologies. At their core, they're narrative, textual, recording and document management systems, and built over the top of that are sets of template building systems and workflow systems to guide people through care pathways. More interestingly, from our perspective, if you buy a primary care system, if you install it at 9 o'clock in the morning, by 10 o'clock, you might not have your perfect configuration, but you can probably be seeing patients because they come pretty much out of the box with everything you need to start. Secondary care systems were pretty much blank slates. They were supplied to users relatively empty, and the trust built their own screens and their own workflows, but most importantly, from our perspective, their own value sets, their own text lists. And some of this reflects the local nature of care pathways. Some of it just reflects how these systems are culturally at the moment. They were often configured by ICT departments who work with clinicians to build local value sets, and they're stored in relational databases. They have a data architecture, they have an informatic architecture, but when you talk about codes, they don't think about SNOMED, they think about ICD. These are codes driven by classification, not by terminology. Which brought us to a problem, because in primary care, we didn't really have to explain what being SNOMED compliant was, because people understood what they needed from their terminology. But as soon as we came out of primary care, the most common question was, what does this ISN mean for us? What does it mean to be SNOMED compliant? And we hadn't told them locally. and we still don't tell them locally. We have 3 national requirements. We have requirements for the NHS, and the ISN, if you look at it, it breaks down fundamentally into 3 parts. One of which is where you exchange data with someone else, the clinical payload of that data will be in SNOMED. You're interoperating in SNOMED CT. Where you're entering new data into your record, SNOMED CT terms should be used when recording that data. And when you're querying that data, the expectation is that that query will run against a SNOMED CT hierarchy. But those 3 national requirements a SNOMED implementation do not make. These are the national needs of the NHS, not the local needs of the care provider. So we try and encourage implementers to think far beyond those levels. A personal opinion at this point, I mean, there's a lot of personal opinion in today, but as implementation support people, I genuinely think, and I think my team would agree with this, that we have a duty to empower organizations and system suppliers to think about their own level compliance and to use this as an opportunity to meet their own local informatics needs. But the problem with that is that the perception of SNOMED is not the global language of healthcare. The perception of SNOMED in secondary care, and particularly in organizations that just didn't use terminologies before, is SNOMED is the big, scary, complicated thing. It's the thing that's going to make your day a nightmare. It's too big. We don't understand it. We can't get our heads around it. Once we as informaticians step outside of the world of clinical informatics, no one is remotely impressed how big our ontology is, or what we claim to be able to do with it. In fact, the next question normally is, what is an ontology? And some of this is our fault because of how we've historically sort of publicized SNOMED, but some of it's just a cultural change that care setting has to make. So what do we do? Well, the first thing we try and do, and what I try and do personally at least, is to empathize and remember what it was to do SNOMED for the first time and to be a non-expert in SNOMED as a terminology and indeed as a technology, and try and empathize with the problems and feelings that people are having. And accept the fact that implementing SNOMED is not just about implementing a terminology. Depending on your care setting, it can come with a whole new influx of new ideas and new technologies and cultural changes and all sorts of other things. I try, when I do first contact with an organization, to listen more than I talk, because I've seen too many times at conferences and at events and things where people go to an introduction to SNOMED CT and people immediately go, right, the logical model, here's a concept, here's a relationship, instead of stopping and actually listening to the people trying to implement it and saying, right, this is what SNOMED could do for you, and only then this is how it works. So when I do a first contact, I try and get a very clear picture of where we're starting from. And my 2 analysts at the moment have been doing amazing work doing first contact for some new care settings. And what we've ended up with is a really clear picture of the starting point for SNOMED. And what I mean by that is where we are in personal knowledge of the people involved, in the systems design, where we are in data maturity, what are our interoperability needs. We find all these things out before we launch into this is the logical model. We then spend quite a lot of time debunking myths, demystifying SNOMED, and letting people know we are actually here to help them. We do explain the big picture as well. It's important for them to understand why we want the NHS in a single terminology. And it's not about an individual care setting. It's about revolutionizing patient care. And you know, I'm a massive SNOMED evangelist, so I always will be. It's why I do the job I do, and I love the job I do. But it's important to let people know that they're joining a really big effort to radically change patient care forever. And SNOMED CT is fundamentally the foundation on which that revolution will be built. But we then have to explain to them that SNOMED is a buffet, not a banquet. You do not have to sit down at the SNOMED table and eat it all in one go. You get to go with your plate and take the things you need and come back and implement those. And then when you're ready and when that has settled, you can go back and grab another plate and you can go back to the buffet as many times as you want. And we explain to them that you can do a phased transition, that you can work towards things, and that's fine. It's not wrong to take the bits of SNOMED you need for now and then consider the bits you might need next. We then spend a great deal of time correcting misconceptions, and only then do we start getting into the science. Which brings us to tales from my email inbox, which I suspect might be similar to some of yours. These are genuine things that hit my inbox at least once a month, often many times a week. People believe that terminologies are replacing classifications, which isn't true. That clinical coders will be out of a job once SNOMED comes along, which also isn't true. That you have to use the whole of SNOMED, that you can't keep narrative notes anymore. Oh no, once you've done SNOMED, it's all forms and drop-down lists. You can't be writing text. That you have to use a browser and a picker. They go to the SNOMED International browser or to our browser, and they think that is how SNOMED must be done, instead of just that's an implementation, which isn't an EPR implementation. That's an implementation for searching through SNOMED. People believe, and I think this might be just a problem that we have created rather than a global problem. People think there's a Refset for everything in the UK. We publish a huge number of Refsets, and I think that's given people an impression that they'll always find the Refset to describe the thing they want. And of course, everyone's favorite, SNOMED is spelled with a W. I do have one near miss. I've only had this once, but it was absolutely my favorite. Please, can you help me with implementation of SNOMED CT, which I think is SNOMED CT. So, misconceptions and how we myth bust them. Terminologies are replacing classifications. Terminologies and classifications have radically different jobs, and not only do terminologies not replace classifications, they work hand in hand with classifications. This is probably, when I go out and do teaching on SNOMED, this is probably my most requested slide by secondary care people. That getting that understanding of how a terminology is different to a classification, the fact that a terminology is about granular information at the time of care for the purposes of care, whereas classifications are about summarizing an episode of care, and they're not for direct care, they're for secondary uses, they're for getting paid, they're for doing statistical analysis and population reporting and that sort of thing. So it's very clear that we need to make people understand that classifications and terminologies work hand in hand. Sort of connected with that, SNOMED CT will make my clinical coders redundant. There's a lady called Monica Jones, who at the time was Associate Director of Information Services at Rotherham NHS Trust, is now working for Health Data Research UK. I believe actually she's spoken on the clinical arm of these webinars, but if you get the chance to hear Monica speak about SNOMED, go listen to Monica speak about SNOMED, she's amazing. She did a case study, Rotherham 5 years on, about her experiences 5 years after a SNOMED CT implementation, of all the things they could do and all the things that have changed. And there's loads of stuff in there, but the one I want to particularly focus on today is about clinical coding. And she states, the clinical coding department has seen significant benefits. They no longer rely on agency staff, they have less staff attrition, and their roles have evolved. Clinical coding is now closely aligned with the data quality role and clinical assurance. Staff morale is higher, they enjoy their more holistic role, and the overall depth of coding in the patient record has increased. What's happening here is this isn't actually ICD-10, this is a coding system called OPCS, which is a classification we use in the UK. And because they could generate most of their OPCS codes automatically from SNOMED in the EPR now, that did two things. First of all, it freed up time of the clinical coding people who are really skilled and are really good at summarizing records, that they could then go back in and do data quality work in the patient record. But also the mappings to OPCS itself would indicate problems with coding, because an experienced clinical coder would look at the thing they were summarizing and go, why has it generated that code? That's not right. And it's generated that code because something's been miscoded in the record in SNOMED. So it doesn't make your clinical coders redundant, it makes them champions of data quality, and that's an amazing thing to have. You have to use the whole of SNOMED CT, the really, really common one. Imagine, if you will, you are developing an iPhone application that takes, I don't know, a blood oximetry reading from one of those things you clip on your finger. It measures your blood oxygen, and your iPhone app is going to connect to that via Bluetooth, wrap it up in a file expression, and fire it off in a file profile to a EPR. How much SNOMED do you need to do that? Do you need the 900,000 clinical and drug concepts in UK SNOMED CT? No. You probably need a handful of codes. You might only need one code, and then you have fully implemented SNOMED CT. We are finding often with mental health that the biggest, scariest thing for them is choosing the wrong code and not knowing where to start. And it's true of anything, actually. If you're trying to do something for the first time and something you're not familiar with, one of the scariest things is staring at a blank piece of paper. So we try and populate that blank piece of paper with a jumping off point. And we go around and we gather the bits of SNOMED CT that other mental health professionals or other care professionals in other settings have said, these are really important. These are the ones I definitely want available in my system. Because remember, a lot of these people are hand cranking SNOMED into their systems at the moment. They don't have terminology browsers as such themselves. They're building value sets manually. So we give them those value sets to start off with. And we say, these are the key elements that you can use to represent the care you give. And we make it clear that this is only a jumping off point. And we ask people to share their value sets. And we run sessions on searching on SNOMED where we talk about filtering hierarchies and checking child codes to see if they're better than the code you've started with. One thing we see often actually is that people coming from a classification like ICD, as you might expect, will often choose a fairly sort of woolly SNOMED code when there's really, really detailed SNOMED codes they could be choosing because they're used to summarizing. They're not used to being precise in their data choices. And actually what we have found, we did some work with some commissioning support units, CSUs. These are organizations that help care organizations with their IT and their informatics. And we did some case studies with them on building SNOMED CT value sets for mental health. And the interesting thing they found was that actually you got a much better result if you didn't start off with your existing value set. If you weren't just trying to say, well, these are the 15 terms we use, let's find those terms in SNOMED, that gave you really bad results. A much better way of building SNOMED CT value sets for new implementers was to say, what are you trying to describe? Don't look at what you've got now. Let's find the right place in SNOMED and let's start drilling down hierarchies and looking at children and looking at what's available. And the quality of value sets was significantly better when they did that. And it's really just exposing them to the content of SNOMED. If they're starting off saying, right, let's do psychotherapy education, go to that element of SNOMED and start looking at the siblings and the child terms, and that provided people inspiration of the detail they could record now because they weren't aware of it. So it was a really useful task to have. Misconceptions, yeah. So narrative notes, this is a really big one. I hear a lot that, oh, you can't keep narrative text anymore. If you take nothing else away from my ramblings today, please take this. User interfaces make or break your SNOMED CT implementation. If your users cannot efficiently and effectively record the data they need to record, then you haven't implemented SNOMED. Just putting a browser in your database doesn't implement SNOMED. We encourage suppliers to collaborate with their users and focus on workflows, but we also encourage users to tell their suppliers what they need. Culturally, in secondary care especially, I think there's become a culture of people sort of getting what they can take rather than asking for what they need. So we're trying to get users and suppliers talking to each other to say, this is what they need. Browsers are great. Browsers have their uses, especially when you're building logical definitions and that sort of thing. But if you're a setting that relies on narrative text, you're a setting that needs a narrative text solution for entering SNOMED CT. And that might be dictionaries and type ahead and autocomplete. That might be natural language processing. That might be something completely different. But just whacking a browser into your EPR does not make your SNOMED CT implementation. And the last one, there's a Refset for everything. And as I say, I think we've probably created this to some degree in the UK because of the sheer volume of Refsets that we produce. A perfectly switched on system supplier came to me about 6 weeks ago and said, I can't find the Refset for that. And that's because that's not a Refset. That's a logical statement about a set of values, in this case for the adverse reaction and e-discharge summary that says valid codes for this are any child of substance or any child of pharmaceutical biological product or any child of the no-known allergy hierarchy or these two specific degrade codes. So we had done a conversation about ECL and we had a conversation about description logic, and they went away very, very excited and off to, I think, download Snowstorm from the SNOMED International website and set themselves up a little ECL engine. And they did that in a couple of days, and then they were doing these sort of queries. So it was amazing. So my day job has sort of been on hold since March, as I'm sure many of yours has been. But we're hoping now the COVID informatics work we've been frantically trying to do, once vaccines is done and long COVID's done, we think we might get back to the day job. So we have our rolling program of education, training and support where we go out and we do first contact to organizations and we listen to their needs and we educate them and we train them and we get rid of their misconceptions and we find out what their implementation should be. We then offer training on the dime tour. So we do the concept model, we talk about SNOMED CT extensions and all that sort of stuff. We have lots of recorded webinars and other things, and we talk about next steps, and almost always particularly for system suppliers, but also for trust organizations. I point a lot of people at the SNOMED International Foundation course. I'm sort of imagining that everyone who's listening to me talk right now has done the SNOMED CT Foundation course. If you haven't, go do it. It's brilliant. And it's just been redone as well since I did it. And several of the people I've sent on it more recently have said how much better it was. So yeah, do check out the foundation course. We do then go into more detail. For EPR vendors particularly, we talk about building SNOMED databases, we talk about transitive closure tables and query tables and history substitution and all that good stuff. We do sometimes also get onto compositional grammar and ECL, and occasionally we get onto machine readable concept models and post-coordination. But post-coordination, we look at them very sternly and we say they're not to do it without adult supervision, because post-coordination, first of all, it's easy to do it wrong because people misunderstand it and think they can just string random codes together, but also it breaks interoperability a lot of the time. It depends who you're sending data to and whether they can handle post-coordinated data. So post-coordination is something which we're going to have to do some more work on to make it more widely available in the NHS. So for now, we steer people away from it. So to sum up, the challenges in mental health, much more holistic, much more about educating, explaining, demystifying, much more about first principles of SNOMED and first principles of putting terminologies into EPRs. These are less complex EPRs in some ways, but they have just as much potential to primary care. And there's much more focus in mental health on end users, not just supporting suppliers, because it's the end users who are configuring the informatics of the system, not the system supplier like in primary care. But they also don't have 30 years of coded data that's gone across multiple different terminologies in its lifetime that we then need to sort out. So that becomes much easier. And I have to say at this point, we could not do the work we do without amazing support from the mental health professionals and the system suppliers. This isn't ever, when we do a new implementation, it's never just about us educating them. They need to educate us on what they need and how their information models work, because we don't know when we go in there. So that's really important. And lastly, and you'll be happy to know very briefly, things we're doing in the future. My job is sort of to put myself out of a job. Maybe I should rethought this career a bit. What we're trying to do is create a set of really, really accessible resources for any new implementer at any level of skill that they can pick up and understand how to plan the implementation that's right for them. There will be documents and things, but we're also looking at a lot of new media. We do a lot of YouTube videos, recorded webinars. We're thinking about wikis and interactive slide decks and all that sort of thing. In March, before the world exploded, I was writing a set of blueprints for adopting SNOMED CT, back to that idea that sometimes staring at a blank piece of paper is the hardest bit. So we started looking at the background and the business case for SNOMED and why you need SNOMED in the NHS. These are all written from a very NHS perspective, as you can imagine, because that's my job. We're looking at planning your SNOMED CT adoption, the people to talk to, the information to gather before you decide what your implementation is, to find out what your implementation should need. We do quite a lot of work on creating requirements, and I'll look at that in a moment, and also assuring your requirements. What we're trying to do, this is just a little example, rather than just say, if we were doing an EPR, we'd have these 30 core requirements. We write 30 core requirements in EPRs that you might consider in your EPR solution, but we also include the reason why that requirement is in there. So people don't just take our requirement blindly, because it might not be appropriate for them, but they do understand the thinking behind having that requirement or not having it. We've got these 30 core requirements, which we explain in some great detail about why they're there and even why they're worded the way they are. We then look at expanding beyond the requirements, reinforcing this idea that SNOMED is something you don't have to do in one big bang. You can come back and do it again and again and again. So we look at different particular areas. This is searching and selecting, things to think about to improve your searching and selecting, things about interfaces, things about filters, all that sort of stuff. Care setting wise, we are particularly interested at the moment in urgent and emergency care. Rapid data exchanges, that exchange of 999 operator in the UK, the emergency phone operator, who exchanges information with a paramedic, who exchanges information with an A&E doctor, who exchanges information with an acute care ward nurse or something like that. So rapid change and multiple EPRs all talking to each other, and how SNOMED can support that interaction through multiple EPRs and care providers. We're also very interested in cancer care. Not only because it has very complex information models, it has multidisciplinary teams. It has teams all looking at the same EPR from different perspectives. What would that mean for SNOMED? Could we be in a situation where a single SNOMED concept needs to appear with multiple synonyms depending on who's looking at it, that sort of thing. I don't know what we'll find in those care settings. We're still information gathering, but it's going to be fun finding out. The other thing that's going to change my job fairly radically is and I have to caveat this with this is amazing and about time. We've now bought a terminology server for the nation. We've bought an Onto server, so people will have a whole new way of accessing SNOMED CT, of accessing not just SNOMED but all our terminologies and all our classifications. and how to link them together and how to map between them and how to upload your own local terminologies so people can work out what their equivalent terminology is to your terminology. It's going to radically change the landscape of informatics in the UK, and it's really, really exciting. Finally, our website, should you need it, I encourage you, if you find it useful, to steal all of our things and pretend they're yours and reuse them. When you start doing SNOMED, you're joining a global family, and we all like sharing things. So this is currently being rebranded, but this is our Kahoot site. The easiest way of finding it, rather than using that rather obscure link, is to just Google SNOMEDLand and you'll find it. Depending on the depending on the Google search algorithms, that should have been, you might find our old Delland site first, which will have a link to the new one. It depends. I don't know how search rankings are these days. In there, you'll find a number of things. I would go straight to the SNOMED CT and mental health section, even if you're not a mental health person, because that's the most up to date. The primary care section has been a bit mothballed for a while. We're also doing a lot of work in the pathology space. I have a sister project, SNOMED CT in pathology, who's designing things like the unified test list and doing all sorts of exciting things with units and values and UCAM. So SNOMED in pathology is there if you want to know all about that. And if you're just interested in SNOMED in COVID, you'll find lots of stuff about that too. So these are the sorts of things you'll find. There's animations, there's webinars, there's useful materials, there's things about analytics. You'll find case studies, presentation slides. That's Monica's case study there. Do go check it out. I encourage you to have a look at it. If you want to play around with Jeremy's mapping tools, they are available on TRUD. Just Google NHS TRUD, you will find it. If you're looking at a Bulgarian newspaper, you've gone to the wrong TRUD. And in there, you'll find the data migration workbench, which is an access-based mapping tool, and you can dig into it, and it's got some really good training materials with it as well. Please don't come and ask me about how the workbench works. I do not know. I've never used it, but I watched other people use it, and it's amazing. And if you wanted to just have a look at our mapping tables and things, you can find them in there too. So I have whittled on at you for a very long time. I would be delighted to start looking at your questions if you have any, and thank you very much.
Thank you very much, Pete, for a fantastic presentation. Very inspiring, and yeah, it was really excellent. But you do have a series of questions if we look in the Q&A session.
So should we just go down from the top?
Yeah, they don't really show from our point in the order that they have been placed. So
I'll go through them in the order I see them.
Yeah.
Oh, hello, Janice. Yes, you haven't yet transitioned to we can, right, yes. So I think the big thing, that there's a number of things that Scotland face which are different to England, and I feel like I'm preaching to the choir by answering Janice's question a bit, but fundamentally the big thing with Scotland is you have a cohort of your own read codes. I think we included them in our mapping anyway, but I can't remember, if I'm completely honest, so we may need to have a look at that. Oh, and actually I'll stop there because Janice has left, so I will get back to Janice separately. Let's go to the next one. Michael Lowley. Oh yeah, good, fantastic question. Why is the SNOMED CT description ID needed in the map? The reason it's needed, let me flick back and so we can see this. 1 second. There we go, right. The reason we need a description ID is if we just had concept ID, we would end up with multiple rows again where we had a single row. All 4 of these rows are concept ID. If we just had that, with our new subset, we'd have 1 concept ID with 2 rows still. So we have to do it at the term ID for 2 reasons. 1, because we'd end up with multiple rows, and 2, because read being read, sometimes we do need to go back to a specific read synonym within a read concept, because different synonyms in read are actually different concepts. So we have to do it at the term level backwards. Otherwise the mapping doesn't work or becomes inaccurate, or we end up getting extra multiple rows. But really good question. Right, let's have a look at the next one. How many systems in the UK use SNOMED terms as their interface technology? Primary care, oh yeah, okay, right. So let's have a think. So all 4 suppliers can use SNOMED CT terms now. We've got 4 primary care suppliers. They all use SNOMED CT terms. Some of them also use their legacy terminologies as well, which is fine. Because as long as the data can come out in SNOMED, we don't mind really how it's entered. So all four of the major EPR suppliers, EPR data, by the way, I spotted that question, electronic patient record data. There's all four suppliers. There's also the major document management system, DocMan. They use SNOMED now as well. For acute, I don't have exact details on acute. I know that most of the major ones, when you look at the Epics and the Lorenzos and the Cerners, they can all use SNOMED. I don't know much about the other acute settings yet. I'm sure I'll get to them, but I haven't actually been personally involved in that. And all the major, we're receiving SNOMED data now from all the major mental health EPR providers. So to a greater or lesser degree, they've got work to do in the area still. We've got work to do with data quality and things, but these are brand new implementers and they've all done a really good first stab. So increasingly, either if they've got a terminology, they've got SNOMED, or they haven't yet implemented terminology and they're still on ICD and they're not really using terms yet. But our hope is that by, I don't know if this is a politically sensitive answer, but I'm going to give it anyway, that I think by about 2025, SNOMED will be pretty much everywhere. Is post-coordination used in implementations? Well, I mean, that's also a good question, but a really, really big question. Anna, did you want to go first on that? A little thing came up saying you'd like to help answer it.
About post-coordination?
Yeah. Maybe it's just Zoom being Zoom. Never mind.
No, post-coordination is certainly a topic that is being heavily addressed at the moment. I can tell you from SNOMED International's perspective, we are working on additional guidance and guidance on how to implement post-coordination and the considerations and technologies required in order to apply post-coordination. And there are also implementations around. I can't go into any details, but it's definitely a high focus right now in various implementations. Yeah.
For us as well, and the impact on primary care, no one's really post-coordinating massively, at least from an interoperability perspective. Some people are post-coordinating internally. We do have a system supplier that post-coordinates family history internally in their data architecture. There's a number of challenges with post-coordination. One of them is actually doing it correctly and following the rules of post-coordination, because people do tend to think it's a bit free form. Secondly, it depends who you're communicating with. If you don't post-coordinate locally and you post-coordinate in interoperation in a message, and then that goes to someone else who then breaks that apart and makes it pre-coordinated statements again, what was the point of post-coordinating? So it's a little bit about joining people up and seeing where the benefits of post-coordination are. There are post-coordinations in data returns. Sorry, Andrew, I'm coming.
No, it's just, it's a very important point to make, that it's not just like post-coordination in the wild. You really need to make sure that you have the underlying mechanism to actually support post-coordination in order to be able to share and use and process the expressions when you apply them.
I don't have to hand my why I'm not going to teach you about post-coordination slide deck, but what I do say is that one of the major challenges, purely from an information modeling perspective and from a computational perspective, is that you can represent exactly the same clinical idea in many different ways using post-coordination, which when you're computing your incoming data makes things very complicated. You've got to build properly intelligent parsers to break apart the post-coordination where you need to do it, or to apply system functions to it. So the basic answer is because it's really difficult and really hard, and it can break stuff really easily. There's a much longer answer we don't have time for today.
But I just stay tuned for the next for the follow-up on post-coordination. There will be something on it from the organization perspective, and hopefully it's not a horror movie. Hopefully it's a fairy tale.
And it just needs people to understand the rules. And you're right, Malcolm Mundy says that the qualifiers are a minefield. They are, but they are all defined. There is a logical definition for all the correct and wrong types of post-coordination, all in the machine readable concept model. So once you understand what that is, the rules are there to be found, and the rules are there, better still, to be computed. But when you first start, it's really hard. Primary care system single exchange data with recodes and SNOMED CIDs, no concept ID, less than ideal. Well, that's true, Richard. I get that. I mean, we have actually extended some of our information models to assume the fact that that you can at least define the concept ID from the description ID, whereas you needed the opposite. You can't do that. So where we had to choose one, we chose description ID. Part of that is actually a sort of a failing of the GP to GP architecture, which is an HL7 version 3 based messaging system, where we've only got one box to put a code and one OID to put that code against. If you don't know what an OID is, don't worry about it for today. It's how you work out what terminology something's in. We had one SNOMED OID. We didn't want to author a SNOMED concept OID and a SNOMED description OID, so we had to choose what to go in there. And it made more sense to put the description ID in than the concept ID. But you are right, it is absolutely not ideal. Can I just be absolutely clear that we replaced historical recodes using clinical valid SNOMED CT concept in every GP system? Well, we didn't replace them, we added to them. So one of the things, yeah, I should have put this on the slide. This is a really important point. Don't get rid of your historical data if you've mapped it to a new coding system. Keep them both, because then people can make an assessment on the mapping. And if they don't like it, or they're not 100% sure about it, they can make that choice and they can look at those things. What I would suggest, have a look through our mapping tables and see if you can spot anything that you think might be a problem. Nothing's come up in live yet. None of our system suppliers have said that there's problems with mapping, and they're now looking after their own mappings for this. Examples of different terminology constraints, different use cases, for example, ECL queries versus lists. New Zealand is quite dependent. Yeah, people generally start off with lists, and we sort of encourage them to go into to ECL queries later, because it saves them a massive maintenance task. But we do have, in primary care, people are starting to basically use ECL definitions for things when they're generating sort of, the values that go in a drop-down table or something like that. Whereas in mental health systems, they are being very prescriptive and they're doing flat lists of codes. So it's this intentional versus extensional. So it is a mixture. Obviously, the flat lists of codes is easier for sort of lower technology implementers, but we encourage them to start thinking about phase 2, maybe replacing those with ECL, because it has huge advantages for maintenance overhead and that sort of thing. But we also make sure that they understand that you still need to maintain your ECL queries. It's not just about, once you've written an ECL query once, you can leave it in posterity. For diagnosis, we're using ICD-10 and also SNOMED CT. What we'll see issues later on. You've got really different levels of information there. So you've got the less granular and the more granular. Sometimes it's really handy to have both. We use OPCS for our procedure classification, and what we're finding now actually is that the main driver for mental health, I don't really have time to talk about it, is not actually EPR data, it's the data return, where they were getting classification data and it wasn't granular enough and they needed more information. So they've moved to using terminological data in SNOMED. And for that, one of the main issue is that everybody who's choosing codes still chooses really high level codes, because that's what they're used to choosing in a classification. So the biggest challenge has been for us to encourage them to go down into the children and say, you could be much more precise. Don't just say intervention. What was it an intervention about? Don't just say mental health assessment. If this was a child and young person's eating disorder mental health assessment, put that in. That's really important information.
Can I ask a supplementary question there? So when you have your subsets, and is that the entire code set that they should pick from, or do you recommend that they actually implement the descendants of the concepts in your subsets when in their system, so that they can be more specific than what you have in the general refsets or subsets?
We encourage it. We've got tremendous nervousness at the moment. People at the moment, I think this is a cultural thing that will change. In mental health particularly, people are very worried about choosing what they perceive to be the wrong code. And we constantly try and reassure them and says, look, is this an accurate description of what you're doing as a mental health professional? Because if it is, it's the right code. And then they sometimes find they're in the wrong hierarchy, which spoils that argument slightly. But the big thing really is look at the term, then look at where you are, and if those two things match, you're on the right code. So it's something we say to them: keep always looking at hierarchies. You might start off with 6 codes in your drop-down list.
Yeah.
But we think that is a starting point, and it's a good starting point, but it's a starting point you should move on from to start finding the absolute best data you can to describe what you want to do. So yeah, it's a moving object.
But when they report data, then can they then report the more specific data, or would they have to have a service themselves that identify what is then the appropriate supertype to report to you?
So if they've got obviously going up hierarchies we can do, and they can do to some degree. So some of these things come in terminology and classification, and they do it that way rather than just within SNOMED. But sometimes no, sometimes we have to do that for them. So we will get data in at a more granular level than we need for a use case, and then we will manipulate that ourselves.
Good.
Yeah. Oh, Charles, hello, Charles. I think we need to help you expand the section. Yes, you absolutely do. Yeah, so really big organizations like BARTS are really exciting. Actually, there's a really good case study from BARTS about SNOMED in Cerner that's also on our website, so check that out. Yes, absolutely. I should say that there's a bit of a weird sort of cultural shift going on in the NHS in England at the moment about what NHS Digital do and about what an organisation called NHSX are doing. And there's a bit of a conversation going on there. So whether that conversation would be with us or with NHSX or both, then yes, please, let's have a chat. Pete, it's challenging enough to try and understand terminology systems for interoperability, but information models are just as important. How much worse is that? Yeah, absolutely. And in primary care, which is very informatically mature, they're very aware of FHIR. They're very aware of information models. One of the things that we find with new implementers as well is that they're not really aware of information models. So they try and put everything in the terminology. It's often what spawns the conversation about post-coordination. And you don't need to get everything in your terminology. Sometimes you need to get individual bits of a terminology into your information model. Lila, yes, please do send me an email and we can have a chat about that. Do you plan to use NLP transformation? Oh yeah, well, see, this is the hot topic now. There's loads and loads of people looking at it. We have also been looking at it. Is Edinburgh Glasgow University doing a huge piece of work on this at the moment as well. All around the world, people are looking at natural language processing and clinical information. It then starts, we get into conversations about AI and actual AI rather than, AI applied to anything with an algorithm. So yeah, I mean, that's a very, very big topic. Yes, we are looking at that. I think we actually have a specialist team looking at that. It's not something I'm looking at personally, but we do have a team looking at the science, and we are absolutely looking at more holistic information management tools. The description logic and things will obviously help with a lot of that to some degree once you've got the information in there. It's possible even that things like moving to concrete domains might help with that. But yes, there's lots of conversations going on. Unfortunately, I'm not an expert in that, so I wouldn't be able to advise you any further. Richard, also GP data, nationally fast solutions, I ignore SNOMED because observations, that will be changing. I suspect. I haven't been involved in the GP data and firework for about 7 years, so I'm not sure what they're up to at the moment. One of the pressures that will come now from everyone is that, and again, this is not maybe politically astute, but I think it's honest. We as an organisation need to get our ducks in a row on certain elements of implementing SNOMED as well. We're very focused on getting suppliers to do it. There are bits of our own organisation that need to do better, and very much so. Yeah, we're encouraging to do that. So yeah, do keep feeding that sort of statement back to the people involved, because that's a really important thing to stick to. Let's have a look. Rather than map description ideas, if happy puppet syndrome is really different to Angelman syndrome, it's not. Happy puppet syndrome and Angelman syndrome are exactly the same thing. They are precisely the same disease. I think happy puppet syndrome, it's a chromosomal disorder. It's a little bit like Down's. I suspect the name happy puppet syndrome, which physically describes the gait of the walk of the people who have it, may well get retired eventually because it's not very sensitive. But yes, no, they are absolutely the same thing. They are synonyms of the same concept. So we wouldn't author a new concept. They are genuinely the same disease. We've covered what EPR data was. Yes, absolutely. Yeah, as I said, and it's good to see you agreeing. But yeah, ECL queries absolutely need to be maintained, and the terminology server will do all sorts of fun and exciting stuff for ECL results and loads of other things. I have to admit, I'm very excited about the terminology server. I haven't got my head around everything it's going to be able to do yet. I'm very keen to speak to my colleagues in the terminology team who are looking after the Onto server and really start exploring what that is. And Ian, hello. Yeah, absolutely. First of type testing was very key. We did a lot of very controlled rollouts. You've got to respect the environment you're implementing, and we, for primary care, had to do a lot of careful first of type clinical safety, clinical assurance, scaled down releases and that sort of thing, just to really not just kick the tires, but really get into the detail of real life data. One of the challenges when you're doing anything in a very informatically mature environment is no matter how good your test data is, it never really stands up to the weirdness of real patient data in EPRs, and particularly weird data that's existed for decades and has gone through various different transitions. You're going to find all sorts of weirdness. So yes, absolutely. Oh, brilliant. Yeah, the Onto server in the UK is going to revolutionize the adoption of SNOMED. It's going to change my job radically, and it's going to enable people like yourself, Richard, and others to do amazing things. And we are genuinely excited about it. It's really big news.
Then we certainly look forward to the follow-up to hear how how it goes with the implementation of the terminology server.
I'll come back in 6 years' time and let you know.
That is a deal. And well done with answering all these questions, Pete.
You're very, very welcome. It's really nice to be able to tell our story. So thank you for the opportunity to do that today.
Sure, it's a pleasure. And as we can also see here in the chat, please go through the positive comments there. That's very good. And I would also like to encourage you who is out there listening, that if you have experiences similar to Pete's or other implementation stories or adventures to share, please get in touch, and we will set that up. And I'm not sure if you're seeing my screen.
I'll stop sharing. There you go.
I'll just try again. So you should be seeing my screen now.
Yep.
Good. So that's all for today's webinar. And before we end, I'd just like to say thank you to you, Pete, for presenting, and to all of you for attending and for your excellent questions. It's very fruitful for a webinar like this when you have so many good questions. The next implementation webinar will be held in Q1 of 2021, and the date and the topic is still to be confirmed. If you are a member of the user support reference group, then you will receive an email with an announcement. But the webinar will also be announced via the news channel and our social media, and we will also announce it on the web series website. And as I said before, please just get in touch if you have ideas and suggestions for future topics. And that's it for me for today. Thank you very much for attending. I hope that we will see each other again next time. Bye for now.